Happy Friday, everyone. It's Angie the Coder, and today's video is going to be all about E&M leveling, evaluation and management service leveling. And we're specifically going to talk about data today. This video was requested by Renee, one of our viewers, and hopefully, Renee, this will help. If not, please put some comments in the comment field below the video, and if you have any questions that weren't answered in this video, and I'll do my best to answer those for you and also for anyone else. So let's just jump on in. The first thing we're going to do is talk about how to find the guidelines, and I am going to go and do a little bit of basics about E&M guidelines first so that everyone is on the same page. If you can always skip ahead if this is too basic for you, but we're going to talk about some of the basics. And the first one is, how do you find the guidelines? I'm going to give you 3 places to go get the guidelines. There are more than 3, but these are the 3 that I'm going to share with you today. In your CPT code book, generally, I would say it's probably always in the front of the CPT code book. Mine is on page 4 is where all these guidelines start. It'll be in front of your evaluation and management services. That's where you'll be able to find a copy of the guidelines for the current year. So if you have your CPT code book out, mine is page 4, and I am using the CPT 2025 Professional Edition that was published by the AMA. But if that font is too tiny for you and you'd like to go out to the internet and take a look, the AMA website houses a copy as well. Their copy, the last copy I found for them out there was from 2023. It was the last major change for these guidelines. The major change. I think there was some tweaking that went on in 24, but it's still a pretty good copy of the guidelines. If you just want a version that's on the internet that's really easy to get to, I put the QR code on the screen so you can use your phone and scan that, and it'll take you directly to their website. And then the last thing I'm going to recommend is for all of those of you that are using the AAPC Codify software. I promise you I am not sponsored by them, but there's a really quick way to get to it in their software as well. So what I'm going to do is I'll show you that right now. This, like I said, you guys can just go there and pull the guidelines up from there. With the scan, it'll take you straight to the AMA's version of it. Well, let me show it to you. Here it is. So let me zoom in a bit for you, and as you can see, it does say these guidelines are effective January 1, 2023. You guys may be able to find a more recent version. I did a little digging, try to find a newer version on their website. I couldn't find it. If you do find it, can you put the link in the comments below so we all have a copy of the newest version that's on their website? But you can see there is the link to this one. And also, if you wanted to look in Codify, you could go into your Codify software subscription or your Codify subscription, click on the big Codify button up here, go to CPT coding down here, and you'll find the guidelines. Yeah, might have went by them. I did go by them. Hey, there they are. Go to guidelines, and the EM guidelines are the first ones to come up, so you click on those, and here are all your guidelines just as they would be in the book. Here they are for you. So I'm going to get down to this because we'll be talking about this soon. There is a nice little MDM table, and I recommend that you guys have a copy of this at your fingertips at all times when you are auditing or coding E&M services. This is the medical decision making chart, and it basically tells you, how to do the medical decision making. As you're probably well aware, you can level based on time or MDM, whichever one works best for the provider, considering that they documented them both. So if they only documented MDM, then you would use just MDM. But if they documented both time and MDM, you are to figure out what the level of medical decision making would support, what code it would support, and then you're to choose whichever is higher for the physician, whether it be time or whether it be medical decision making. All right, so let's get back to the presentation. That's where you can find this stuff. And as I was just saying, to recap how the new guidelines work, you can level a service based on time or medical decision making, and that depends on which one's most advantageous for the provider. based on their documentation. But since we're talking about medical decision making, or MDM is what I'm going to refer, I'm going to use the acronym MDM going forward in this presentation, then these are the three elements that we're looking at. We're looking at number and complexity of problems addressed, or NCPA. We're looking at the amount and complexity of data analyzed, or data. That's how I'm going to be referring to it going forward. And the last element is risk of complications and or morbidity. And I'm going to be referring to that as risk. So those are the three elements, and as you probably already know, you must meet 2 of the 3 in any given level to support that level of E&M. But today we are going to focus on the nuances of data because that's what was requested, and I think it was a great idea. So for levels of data, there are 4 levels. You have minimal, limited, moderate, and extensive. So minimal, we're just going to go back to the chart. Actually, we're going to use this one. This one's easier to read. The font is just easier to read. So remember I said for levels of service, based on MDM, you must have 2 of the 3. So the 3 elements are in the columns here. You have NCPA, data, and risk. We're focusing on the data. So let's talk about each of these levels of data. So the first level of data is minimal, and it'll be one small, like maybe they might order 1 test or nothing at all. So it's very little right here. Now then after minimal, you go to limited. For limited, you must meet one of these 2 categories below. The first category is all about tests and documents. So you must have a combination of 2 of the following. It's the review of prior external notes from each unique source, review of results from each unique test, or ordering of each unique test. So you must meet, to get this category, you must get 2 of these. So, and it can be any combination. So if your provider ordered 2 tests, then that's enough. You don't have to have these other 2. And then the other category is assessment requiring an independent historian. So this is where a patient comes in and the physician is required, or provider is required, to get history from someone other than the patient. Maybe the patient was unconscious, maybe the patient has dementia. For whatever reason, it's required that they have to get a history from someone else, and when they document that, it automatically counts as category 2. So they would meet this category 2 and be it limited with no other documentation of data. So if that's all they did for data, that would be enough to be at limited. So moderate is the next level. And moderate, you must meet one out of the 3 categories. So there's 3 categories down here. The first one is kind of similar to what we saw above. It's tests, documents, and they've included the independent historian. So this is reviewing external notes, it's reviewing tests results, it's ordering tests, and it's an assessment requiring independent history. Once again, you don't have to do them all. You just have to get 3 of any of these. So if the provider reviewed a unique test and then they ordered a unique test and they got that assessment, that would be enough. If they reviewed records and then ordered 2 tests, that would be enough. So it's any combination of 3. So category 2 is another category. And if they do this by itself, if this is all they document, this would be moderate data. If they did an independent interpretation of a test, so say they did their own interpretation of an MRI, or let's say a chest x-ray that they didn't bill for, and maybe another doctor did it in another specialty. So maybe this is a cardiologist or a pulmonologist who's looking at a chest x-ray that maybe the ED doctor did, and he's given his interpretation and his assessment and plan. He's saying, my review of the chest x-ray film shows that the patient does not have pneumonia, or whatever he says. So if he documents that, then he gets automatically moderate data because he met this category. And remember, you only have to meet one of these 3 categories, and that by itself meets category 2. But category 3 is the same way. It's if they just do this, it's enough to meet moderate for data. So category 3 is discussion of management of the patient or test interpretation. and it has to be with an external physician or other qualified healthcare provider. So say you have your family practice doctor, and he documents that he reached out to the cardiologist about the hypertension. If he documents that cardiologist is in a different specialty than him, even if it's in his group, even if they all work for XYZ physicians, they're in two different specialties. And so if he is reaching out to this provider and talking about, I'm thinking maybe we should take them off of this hypertension drug. What do you think? And they're discussing that. Or he's asking about the echo. Maybe the cardiologist did an echo and he has some questions about it. If he documents that, then he automatically meets moderate for data. All right, but then we get to extensive. For extensive, they must meet two of the three categories, and it's the exact same categories we saw for moderate, so I don't need to repeat them. It's exactly the same thing, but you'd have to meet two instead of just one. So let's say they met this. Maybe they ordered 3 tests and then they reviewed a test, and then they did an independent interpretation of an x-ray. That would be enough to be extensive, and that's as high as you can go with data. So that's the highest level. So that's how this works. All right, let's talk about the different types of data. We have actually covered those a little bit in the previous slide when we were talking about, I showed you in the grid, but we have review of prior records. We have review of test results. We have ordering of tests. We have assessment that requires an independent historian. We have an independent interpretation of test. And then we have discussion of management of a test, or test interpretation, discussion of test interpretation with an external physician or other qualified healthcare provider. And when they say that, they mean like your PAs, your physician extender type people, and some others, but mostly they're talking about PAs, nurse practitioners, certified nurse midwives, those kind of staff that are physician extender type staff. All right, so now we can jump into the concepts regarding data. So when you read the guidelines, you'll see there are a lot of, I'm using the word concepts because I can't think of a better term for it, but there's some concepts and some things that you need to understand about how to count things. So we'll start with some concepts around reviewing prior records. So for a provider to get credit for reviewing a prior record, it must be from an external source. So like an external physician or an external other qualified healthcare provider or QHCP. Like I said before, it needs to be someone who's not in their specialty in group. So it can be a provider in their group. So say they are XYZ physician practice group and they have multiple specialties. If they are reviewing prior records from someone outside of their specialty in that group, they can do that, but they can't get credit for reviewing one of their peers in their specialty in the group. So it has to be someone outside of their group specialty. And it has to be, they talk about unique source, and this one is kind of interesting. So the review of all records from one unique source is counted once. So let's say the patient comes in for consultation with the pulmonology doctor, and the primary care provider has sent over all her records, and this pulmonologist reviews, say, 20 days of data, or he reviews some tests that the pulmonologist did, and he reviews the notes from the pulmonology visits. That's one unique source. All of that is considered as one. Counted one time. All right, so what about reviewing prior record? Oh, we already talked about that, sorry. So assessment requiring an independent historian. So that's another type of data that we've kind of touched on. First of all, the word required is in the description. It must be necessary. It must be medically necessary. The patient is unable to give the history. They may not be able to give it because of their current physical status. Like maybe they are unconscious, or maybe they were unconscious when it happened and therefore can't give a history. They could be having dementia. They could have memory loss. They could be too young to give a history themselves. There's all kind of reasons, but it needs to be medically necessary for the provider to get a history from someone else. And it can be obtained in the guidelines. It says from a parent, guardian, surrogate, spouse, or witness. This is something I was aware of this, but a lot of people are not. They don't have to get this in person, so they can call the witness or the guardian or the parent. They can obtain it via, they don't have to be face to face with the person they're getting this history from. All right, ordering and reviewing tests. There are actually two different elements. There are two different types of data. You've got ordering tests and you've got reviewing tests, but I put them together on this slide because I wanted you to understand some concepts. According to the guidelines, you count data when tests are ordered, because they say that tests are presumed to be analyzed when they're ordered. So basically what they're saying in layman's terms is, if a provider is going to order a test, they expect that provider to want to analyze that and to need to analyze that test. So they're only going to give you the provider credit for it one time. And they say to give credit when it's ordered, if it's ordered at an encounter. And that kind of brings up the exception. So if it's not ordered at an encounter, you would count the data when it is analyzed. So say in between office visits, Mrs. Jones, Dr. Smith orders maybe a A1C for Mrs. Jones because she's been complaining about symptoms of diabetes. And so he orders it he orders it between visits. He's not actually with her when he doesn't see her. He's not having an encounter. She's made a phone call in. She's talked to maybe the nurse or something in the office, and she said, I'm having some dizziness or whatever. And he's like, we probably should check her sugar. Let's send her to the lab. So he sends her for her A1C, and he says, now I want her to come into the office and we're going to discuss the results. So she comes into the office and he says, your A1C was high, and what I need you to do is start taking this anti-diabetic oral drug, or maybe, even if it wasn't abnormal. Say he calls her in, then he sees her and he tells her it's not abnormal. Generally, they're going to call him in if it's abnormal, but if he analyzes and reviews that data at the visit when the patient comes in, then you could count it for a review of the test. So, but normally, like if Mrs. Smith came in for her visit and he ordered a CBC, and it was, he would get credit for that CBC when he ordered it, even though it may come back for him to analyze a few days later. They're expecting you to give him credit when he orders it. And so why is this important to coders and auditors? It's important because when we look at the record, we have to, if we see where a provider is reviewing a test, we have to think to ourselves, can we give him credit for reviewing that test in the medical decision making? Did he order it at the last visit? Or did he order it when there wasn't a visit? Did he order it between visits? So if he ordered it between visits, then yes, you can give him credit for reviewing it. But if he ordered it at the last visit, then he should have got credit then, and you would not give him credit again. So these are things you do. A lot of times in coding we think, we don't have to look at the whole chart. We need to focus on our one day. Well, you do want to focus on your one day, but you are going to have to go back and look and see, have we counted this before or not? If he ordered it at her last visit, then it's assumed that we would give him credit then, so we're not going to give credit again. The other thing is that you can count the review of a test if it was ordered by an external provider. So let's talk about that. So, Dr. Let's say Dr. Jones is a PCP and his patient went to the ED over the weekend, and they had I'm going to use my husband for an example, and they had a cardiac enzyme done in the ED, and then they were told to follow. They were told it was fine, but follow up with your PCP. So he goes in to see his PCP, and his PCP will pull up that lab in the system from the hospital and say, oh, I see they did, I see they, and he has to document this. I see they did a cardiac enzyme on you, and the good news is it came back clean, so there's nothing we have to do about that. If it's as the PCP, he needs to look at that, especially because if he's treating the patient for hypertension, he needs to know that. If he's treating the patient for maybe coronary artery disease, if it is relevant to why he's seeing the patient, and then he can count the review of that test because he didn't order it, someone else ordered it. He's not going to bill it, he didn't order it, and he gets to he gets credit for the review of that test because he hasn't been able to count it anywhere else, and he is using it to manage the care of the patient. All right. What about when a provider writes a recurring order? That trips some folks up. That trips some coders and stuff up. But they give very clear guidance on that. They said what you want to do is give credit at the encounter when the recurring order is written. And a good example that they gave was the PT time test, that CPT code 85610. So you have a provider that might say, I want this patient to have a PT time test every month. I'm not sure if that is medically right. Maybe it's more often, maybe it's less often, but we're going to go with a month for the purpose of this, since I'm not a nurse or a doctor. But just for example, so patient comes in and the provider orders them a PT time test and says, it's going to reoccur. I want it to be done every month. And so you would give credit at the encounter where they ordered it. And then each time the patient came back and the provider reviewed a unique PT test, Prothrombin time test, you could give them credit for the review of that if it's at an encounter. So let me see if I can walk this out for you. So January 1st, Ms. Smith comes in and she's on Eliquis, and the provider says, or some kind of blood thinner, and the provider says, I would like you to have a PT test every month. All right, on that visit on January 1st, he gets credit for ordering that reoccurring lab series, right? That reoccurring lab. Now she comes, sorry about that. So she comes back in February. Let's say when she comes back in March. Say she comes back in March and he is reviewing the February PT time test with her in March. So it's a new test and he's reviewing it with her. He gets credit for reviewing that test. That's assuming he's not billing this. Now, if he can bill the 85610, that's a whole nother story. We'll talk about that later. He won't be able to get credit for it. But say he's sending her to an ambulatory care lab, he's not going to get to bill it. The lab is billing it. Then whenever she comes back in March and he's looking at that last PT time she had, it's a unique one. It's every month she has a new one for him to look at, and every month he sees her, he looks at it, and he makes the decision to keep her drugs the same or change them. Then he gets credit for actually reviewing that PT test, as long as it's unique. He can't, he can't look at February's twice. He can only look at it once. He gets credit for reviewing it once, and the next time he gets credit for reviewing March. The next time he gets credit for reviewing April. And it has to be at a patient encounter because you're counting it towards the MDM. I think that pretty much sums up this slide. So yes, you get to give credit for ordering it and when it's ordered, and also reviewing it subsequently down the line each time he reviews that lab at a patient encounter, as long as he's not reviewing the same the same lab result. So he can't review February's lab twice. He can only review February's lab once, March's once, blah, blah, blah. All right, separately reported tests. There's a lot of discussion in the guidelines about separately reported stuff. You can't count it if it's separately reportable. This is all about the double dipping. They're not going to allow double dipping. It's not allowed. So you cannot count a test if the professional component is separately reported. For example, if your doctor was able to bill for the interpretation of a chest x-ray, then you would not give him credit for ordering or reviewing or independent review of that chest x-ray, because when he bills that code, he gets credit for that, and he would not be given credit twice. You can count tests if there's not a professional component. So a lot of people may, and I will tell you, when these guidelines first came out, I struggled with this. Lucky for me, I had some really great people around me that got me straight. But as codes like labs like the CBC 85025, the basic metabolic panel 840, whatever that one is, 80048, a lot of the labs that you guys are going to see in the clinic a lot, you can, if your provider is billing those labs, as long as they do not have a professional component. For instance, the CBC does not have a professional component, your provider can bill it, and they can also get credit for ordering it at this, if they ordered it in the encounter, even though they're going to bill it, they get to bill it. They get to get credit for that order. So just know when you're looking at tests, know if there's a professional component or not. An x-ray has a professional component, so you have to be careful with those. A lot of your clinical labs do not. Look them up in your code, if you have an encoder, look them up in the encoder and see, is there a professional component or not? If there's not a professional component, you can bill those out and also give credit for order in the lab in the medical decision making. All right, speaking of labs, lab panels count as one test. So if the provider orders a lab panel, for instance, the basic metabolic panel, you can only count that once. It consists of 9 separate labs. Each one of those labs has its own CPT code. It doesn't matter. Because it has one code, 80048, you can only count it once towards data. So if they order a basic metabolic panel, if they order a comprehensive metabolic panel, if they order a renal panel, if they order a lipid panel, a panel equals one point towards data. So you only get to count it once. Unique test. This is one that I recommend we slow down and pay good attention to, because this is a concept that I think that some of us aren't paying. I feel like I haven't paid enough attention to this over the years. So I am glad that I am doing this video, because it made me really pay attention to this. Unique tests. So serial tests, for instance, serial glucose. These are the examples they used in the guidelines. You can go out there and check me on it. But serial glucose, you would only count that once if multiple results were reviewed at the encounter. So say Miss Smith comes in and Dr. Jones is looking at her serial glucoses, and he's looking at 10 serial glucose results for her. At one time, at the encounter, you can only count it once. Even though he's looking at, when you and I are looking at the chart, we see like serial glucose from this day, this day, this day, this day in time, this day in time, this day in time. We can't count each one of those individually. It's all one. You can only count it once. Overlapping elements. Overlapping elements, this is another one I found interesting. So, and I don't know that I've actually seen one of these out in the wild. If you guys have, let me know in the comments. But say, for instance, a provider attempts to bill on the same day, and maybe this is in the inpatient setting. I don't think you're going to see it in the outpatient setting, but you might see it in the inpatient setting. Say they bill a CBC, or say they're rounding on, they're seeing a patient during the day. Maybe they round more than one time, but needless to say, let's say during that day they order a CBC with auto diff 85025, and then they order also a CBC without diff 85027. For whatever reason, they do it this way. You cannot report them both. You can I mean, not the test, like the actual labs can be reported, but you cannot give him credit for ordering 2 labs, because even though he ordered 2 labs, clearly he put in 2 orders, 2 labs were drawn, 2 labs were resulted. He can only get credit for ordering the 1 lab. And the reason why is because they have so many overlapping components. Both of them have a hemoglobin, hematocrit, red blood cell, white blood cell, and platelet. Both of them have that. The only difference is one comes with autodiff and one does not. So they have in their guidelines that you should that you would not report them both. You only get credit for ordering one. So there's that. That one's one that surprised me. When I was going through these guidelines with a fine-tooth comb. Like I said, I'm not sure I've run into it, but now I know to be looking for it. All right, independent interpretation. Do not give credit for independent interpretation if the provider has reported the CPT code for the service. So if your provider is doing an independent interpretation of a chest x-ray, a single view chest x-ray 71045, and they build that 71045 out, then it's fine that, it's good that they build the 71045 out, but they cannot get that moderate data element for doing that independent interpretation. You'd have to throw that out. And that's why it's important that we look at the whole picture sometimes. As a coder or auditor, it's our job to say, can my provider bill that? Does he normally bill that in this setting? If you have access to look at the claims, did he report a service for the chest x-ray? Did it go, did he report that? You need to be aware of that, because he can't get credit for it both times. If he's going to bill it out with the CPT code 71045, he cannot get credit for that independent interpretation of the service. However, if another provider in a different group does it, he can. So if the test was ordered or reported and billed by a provider in a separate group specialty, he can. He can't do it if one of his peers do. So that second bullet that you see under do not count, if your provider, Dr. Jones from family medicine, is trying to take credit for an independent interpretation for a single view chest x-ray, but his peer, who's also family medicine or internal medicine, whichever one I said, his peer in the same group specialty build out the 71045, he can't get credit for it. But he can if he's doing an interpretation of a chest x-ray that someone outside of his group specialty ordered and billed for. So there's that. And I think a lot of coders have this down now, so I won't belabor the point. But just make sure when you're trying to give credit for an independent interpretation, did my provider bill that? Is he going to bill that? That's important to know. All right. There were some things in here that I thought were interesting. Discussions with external providers. So if your provider has a discussion of management or test interpretations, first it has to be, with an external provider. But one, it requires an interactive exchange. It can't be through a third party like the clinical staff. So he can't tell his MA to reach out to Dr. So-and-so and ask him such and such. No, it needs to be him reaching out to Dr. So-and-so. He can't do it through the third party. And he can't just put a note. Now, I remember back in the day, because I've been doing this for a long time, I remember back in the day when the handwritten charts, where they would scribble a note in the chart and ask the doctor, they would communicate back and forth with each other in the chart. That will not count for this. You cannot use that. It does not have to be on the same date of service. That was the aha moment for me. I missed that in these guidelines, and I was always expecting the provider to have that conversation on the same day of the encounter. So if my provider was rounding on this patient on January 1st and he documented that he was going to have a conversation with the ED doctor or the radiologist, let's say the radiologist, about the MRI, he has a question about the MRI, I was expecting to see that in that documented that conversation took place on that day. And the guidelines say, now this is not Medicare guidelines, these are AMA guidelines, so we may want to dig into what Medicare has to say about this, but the AMA says it does not have to be on the same date of service, but it should be initiated and completed within a few days. Before you latch onto this and go crazy in your audits, contact your Medicare carrier, your MAC, and ask them if they agree with this for your Medicare patients. I would not, this is the AMA's guidance, and it's really good guidance, but before you go crazy and hog wild with this, talk to your MAC. But it should be initiated and completed within a few days. It does not have to be in person, and it can be asynchronous, so it doesn't have to be like a telephone call. They can email back and forth with each other. It does not have to be in person. I mean, it doesn't have to be. It can be asynchronous, so it doesn't have to be, like live phone call or something. And it must be with an external physician or other external qualified healthcare provider. Like I said, this part of this I was really surprised about. But I would not audit based on this until I check with the MAC for the provider that I'm auditing for. So take that with a grain of salt about it doesn't have to be on the same day until you talk to your MAC. All right. Did you know, here's a few more interesting things. Did you know that the pulse ox is not considered a test for the purposes of counting data? Pulse ox is really basically considered more vital signs, more of an exam than data, so you are not to count that towards your data. The review of behavioral assessments, such as a PHQ-9 and a GAD-7, that those can be counted as review of data. This will come up a lot with especially your providers who are doing pain management and whatnot. Review of a state's automatic prescription system is counted. So if you have a note where your provider says, I'm in North Carolina, and he says that he went, he looked at the North Carolina's database for prescription management. If he documents that he checked that and everything looked good or whatnot, then you give him credit for review of data. Did you know that the review of all material from one unique source is only counted once? You do now because I said it in one of the previous slides. And then the last one was, did you know that an order of an x-ray of the left and right arm is counted as two tests, that you ordered two tests that the provider did? And I will tell you where this came from. These are from a MAC. I actually went out and looked at the frequently asked questions for Noridian. Noridian may not be your MAC, so you may want to double check with your MAC, but it was interesting to see how a Medicare carrier actually looked at some of these things. So most of this came from here. See, it'll go there. And this is bringing me to my next, let me go to the top here. So this is Noridian. My goodness, what just happened here? Okay. These are their frequently asked questions about data. I think it's data. Yeah. So this is let me go up here. So if you click on each one of these, it'll take you to different sections. But each one of these, it'll give you the frequently asked questions that the people have been asking this Mac about data and what their answers to those are. So there's more here than what I put on the slides, so definitely go check it out. And my recommendation is that you figure out who your Mac is if you don't already know, and you go find their website and you look for frequently asked questions about E&M services and see if you can find something similar. I can tell you that I know for a fact, I'm pretty sure Novitas and Noridian have similar education like this on their website. I haven't seen a lot. My Mac is Palmetto. I don't see a lot of this for Palmetto. You're welcome to go and check behind me and see what you can find. Let me go back to here. Now you have here's the QR code again, in case you do have, if Noridian is your Mac, you might want to go ahead and take another look at that. And it's not, like I said, they have more than just the data. They also talk about NCPA, they talk about risk, they talk about data, they talk about time, they talk about all the things that you might be interested in, especially if Noridian is your Mac. And so that, like I said, that brings me to another thing, and that's that each one of you probably need to go out there and take a look at what your Macs have in their education for E&M services. I will tell you that WPS has some great webinars that are on demand about E&M leveling and how they count things and what they allow and what they don't allow. I didn't think they had a lot in writing, like the frequently asked questions. They didn't have a lot of that, but they do have some really great webinars where they answer people's questions in the webinar, and they are on demand. I don't have that queued up so I can pull it for you, but if your Mac is WPS, you may not see a lot in writing, but you can find some really great videos on demand out there where they've done training on it. Like I said, I don't think Palmetto has a ton. My favorite two to look at are Noridian and Novitas. They have a lot. First Coast might have a little bit too, but Noridian and Novitas, they're very good with their education on the E&M. So that's my takeaway to you, is you might want, and we might do some videos on that where I go out and I show you what the individual Macs are saying about some of these things. Let's see. So that's really basically all I have for you today. If I didn't answer all your questions, leave your comments in your questions in the comment box below the video, and I will do some research and see if I can find your answers. If you know your Mac, you might want to put who your Mac is so that I can see if I can find anything from your specific Mac. But I hope this helped. I hope I was able to bring some stuff to the table that you haven't seen before, and I do want to share the resources. These are, I think that's all of them. These are the resources that I use, the sources that I use for this video. You're welcome to screenshot this real quick. I gave you the QR codes that I created for some of them, but here are the actual links. So feel free to screenshot that. And I do appreciate your attention, and I appreciate your time. I know there are other things you can be doing than watching my videos, so thank you very much for staying this long. Put comments in the comment field if you can think of any kind of video you would like to see on coding or auditing in the future. And thank you very much. Where's my thank you? I don't have a thank you in here, but thank you so very, very much for liking, sharing, and subscribing to my videos and channel. I appreciate all of you, and I look forward to hearing your comments. Thank you, and have a great day.